Muy buenas tardes a todos. Muchísimas gracias por permanecer y empezaremos una serie de sesiones como todas muy importantes y tenemos el gusto y el honor de que esté con nosotros personajes muy importantes en el campo de la hipertensión arterial. La siguiente plática va a ser dada por el doctor Reinhard Kreuz. Él es un farmacólogo clínico muy conocido en todo el mundo. Él trabaja en Berlín, en el Hospital Charité de Berlín, y fue presidente de la importantísima Sociedad Europea de Hipertensión entre 2019 y 2021, y fue co-chair de las guías últimas de esta sociedad del 2023. Y precisamente nos va a hacer favor de explicarnos las características de estas guías. Welcome again, Professor, please.
Buenas tardes a todos. Thank you very much again. It's a pleasure for me to be here. Thank you for the kind introduction, Dr. Alcocer. Show my conflict of interest. I'm talking about some of course, the European guidelines. You see on the left, the European Society of Hypertension, in the middle, European Society of Cardiology. I intentionally also have to put into the context American, your neighbor country, because you will see probably the American guidelines have some influence and the mindset of some European guidelines, and it's a question of controversy and discussion. So particularly for the young, I'm so thrilled to see you have so many young people in Greta. Maybe it's helpful to address some of the issues. Sometimes you have also academic, I call it an academic conflict of interest. You know, the societies like to write their own guidelines, and maybe we have also some negative aspects if we have too many guidelines and too controversial guidelines on the topic of hypertension management. If you are interested why we do not have joint guidelines with the cardiology guidelines, we had in the past joint guidelines, European Society of Hypertension, European Society of Cardiology. I don't go into details, but we even published a paper on this. Basically, the take-home message is the Cardiology Society didn't want to continue our collaboration, so we stopped it, unfortunately. But maybe look in the future, I will comment on this. This is the Global Report on Hypertension Control, and meaning the blood pressure below 140/90, recently published in the JACC, also by Paul Welton and other colleagues, you know, and the take-home message is that even if the diagnosis is made, overall globally 35 to 70% remain untreated. Among those who do receive treatment, 50 to 80% do not reach a target level below 140/90, below 140/90. And Dr. Alcocer yesterday presented some data indicating that about 50% with hypertension are untreated in Mexico. And among those who do receive treatment, 2/3 do not reach a target values below 140/90. And I think this, it's not only patient adherence, it's not only inertia of physicians, it's also some academic aspects that influence the complexity, and we should, you know, try to avoid this in the future. I'm not proud about this picture I have to show you. Different definitions of hypertension, normal blood pressure, elevated blood pressure across the European guidelines, and this is kind of confusing. I come back to this. We mentioned this already yesterday. We have the full guidelines, and we try to focus now, all societies, I guess, more into implementation and to improved management, and therefore we developed the practice guidelines and the master plan. I will use this also as a didactic tool to discuss now with you the current status and some issues in the European guidelines. Let's start with the definition of hypertension and measurement, as Professor Stelju mentioned yesterday. So first of all, there's some differences. I indicate in my slide, if you see a delta in the blue box, you will see that there are some differences between the Society of Hypertension Society and the ESC and the American later on as well. So we simplified the classical recommendation. We have only two, no different colors, 2A or B. 2 is an option. 1 is something we should do. 3 is something we should not do. 2 is an option. You know, we have a lot of options, but sometimes we are not clear about this. Also, in the yellow circle, the ESH guidelines are more conservative. That explains some differences. Conservative in a way, a class 1A, evidence level A, was only assigned in our guidelines if there's a trial, a randomized controlled trial, that showed a benefit in outcome. Blood pressure alone, not A. Outcome, stroke reduction, mortality, cardiovascular, myocardial infarction, A. And that's the difference. That's also why they are a little bit more conservative. You know, we have experts in the guidelines. I'm not so stringent, but there are some very stringent persons in the guidelines committee. They say, okay, all randomized controlled trials used only office blood pressure. All trials used only outcome trials, office blood pressure. Therefore, the basis for treatment and all definition, etc., is the office blood pressure. That is one difference compared to ESC and also American Heart ACC. They not only used outcome trials, but they also used surrogate trials or blood pressure lowering trials. So the difference is in the ESH, the basis is office, but we stated that use out of office whenever deemed useful and feasible, while ESC and American Heart are more, prioritize for the diagnosis, the confirmation out of office blood pressure measurement. That is also due to the different methodology in some aspect, as I wanted to explain. So since the WHO, since the 90s, and the ESH guidelines did not change the definition of hypertension, the grading, etc., is also the same, it's arbitrary, but it did not change in the current guidelines. There is a major difference. Now, in terms of the non-hypertension classification and the elevated blood pressure and the management in the ESC and the American Heart guidelines. Now, the ESC consider that if you have a blood pressure of 120 to 70, it's elevated. 120, 121, 71 is elevated. You may even start already considering risk stratification. And that's a difference. You may wonder why. They are also closer to the Americans. If you look at, surprisingly and ironically, to the chairpersons, the coordinators, there are 4 important positions in the American and the ESC guidelines, 3 of which are by persons who work in the United States, in Harvard or in Canada, North America, or in Baltimore and Johns Hopkins. So the ESC kind of merged a little bit with the mindset with the American guidelines that explains some differences in the European guidelines. Our guidelines, the ESH guidelines, are supported by the International Society of Hypertension and by the European Renal Association, which is also very important in hypertension management. We stated, I don't want to read out, basically, that the blood pressure lowering treatment in most patients with office blood pressure below 140/90 is not beneficial. It's not shown in randomized controlled trials. There are no single trial that showed if you treat patients without hypertension, prospective randomized trials, that you have a benefit. And these are old data, meta-analysis, and one single trial, the HOPE-3 trial, and this is still valid. We do not have that yet. That's the reason why we keep the 140/90 definition in the ESH guidelines. We need, of course, an operational definition for hypertension, for body mass index, for type 2 diabetes. And where is this based? Because on the outcome trials. I intentionally put this slide here. We should not confuse ourselves and mix primary prevention, what Eugene Braunwald, who unfortunately passed away 2-3 weeks ago. I had the privilege to work in the Brigham and Women's Hospital in the 1990s, 4 years, and he was the boss of the Department of Medicine. And I met him and I collaborated, actually, supported myself. So I put this intentionally. Of course, a lower blood pressure is very important for prevention, lifestyle, etc., below 120/80, primordial prevention. That's what he stated in his editorial. But we should not confuse prevention or epidemiology with intervention, evidence-based intervention. And based on the interventions, the randomized control trials that we have, we view that the definition, we assume that the definition, or we anticipate the definition is still 140/90. As we see here in this, I put the threshold into the epidemiological context that has been published in the landmark study by Levington 2002. So we have to differentiate between epidemiology. The risk increases, of course, from 115 systolic or 75 diastolic, but we have only evidence to treat patients with hypertension 140/90. That is our position. So in the ESC, and there's the difference, in the American Heart, there's the difference. They recommend to treat already patients with a blood pressure 130/80 with pharmacotherapy or even with lifestyle if the blood pressure is even lower. And in the ESC guidelines, they have two references to support this. A meta-analysis in the Lancet from the Oxford group and a meta-analysis from Kostas Tomopoulos, Gianfranco Paratti, and the late Professor Zanchetti. So I know the meta-analysis very well. I phoned Kostas Tomopoulos. I asked him, does your meta-analysis support the conclusion that we should treat patients with 130/80? He said, no, it's not justified to show this reference. And the Rarimi meta-analysis is full of problems. We published several papers on this, full of problems. We do not accept the meta-analysis. So in terms of assessment, so this definition and the major problem, but there are many similarities. Now we can relax a little bit. The essential information in terms of treatment management of hypertension is very similar in the European guidelines and actually also in American guidelines. So we saw yesterday in the master plan assessment, basically there's a lot of expert opinion in the assessment, what we should do and how we should do, of course. And there I would like to point out only one major difference probably. And we have seen the infographics. We discussed this with a nice case presentation together with Martin yesterday. So this is a summary in the master plan and the practice guidelines. But with regard to the assessment, there's one difference. We stated in the ESH guidelines, okay, primary aldosteronism is a very important secondary form of hypertension. We have these nice infographics. And it should be considered in selected patients, of course, and aldosterone-renin ratio measurement should be done in selected cases. While the ESC recommends, at least with the two recommendation, everybody, it's an option, and they basically everybody with hypertension 140/90 should have a measurement of the aldosterone-renin ratio. There's also, again, an academic conflict of interest, potentially. The European Society of Endocrinology, of course, they want to promote the importance of primary aldosteronism. They supported the ESC guidelines, and therefore that's a subtle difference. We can discuss this if this is valid. I think it's very difficult to do in all patients aldosterone-renin ratio. Yeah. Now, in terms of selection of therapy and treatment approaches, actually, they are very similar. We have seen this infographics yesterday already. We treat all patients at very high risk. The patient we had yesterday, of course, is very high risk, but also symptomatic patients. Most patients are asymptomatic, but if the patient is symptomatic, there's another indication or indication, yes, to initiate treatment. But there's also a difference now in the European guidelines, another important difference potentially. So we argue that if you have a very low risk, a young patient, very low risk, has hypertension, no risk factors, just above the threshold, hypertensive, 140, 140, 45, 42, whatever, you may wait with lifestyle intervention for some time before you start actually drug treatment. So this is also an expert opinion, but we did not intend to that all patients should immediately be treated. That's different in the ESC guidelines. You can read, if you have the patient with a blood pressure of 140/90, pharmacotherapy should be initiated promptly in all patients. rather than, wait in some patients with a low risk. That's a difference in terms of general management. In terms of pharmacotherapy, we have seen this slide again. We have the big 4 or 5 as first-line drug treatments in the ESH guidelines. The ACE inhibitors, the angiotensin receptor blockers, which should not be combined, and then the thiazide-like diuretics, the CCB, the calcium channel blockers, and the beta blockers. And there's a difference here with regard to the positioning of beta blockers in both guidelines. Of course, we have guidelines-directed medical therapy. Let's say patients clearly with HFrEF rarely have hypertension, patients with angina, coronary artery disease, arrhythmias, where you have guideline-directed medication therapy with beta blockers, and the 2 guidelines agree, the ESH and the ESC. But we mention also in the ESH guidelines that beta blockers can be used in many other favorable conditions. And this is this table where you have guideline-directed medical therapies, such as acute coronary syndromes, chronic coronary syndromes, and heart failure, hypertension disorders in pregnancy. But there are, I don't want to go into details, there are at least 19, we listed here 19 other conditions, where beta blockers may be favorable, not on directed outcome trials, but on indirect evidence or observational evidence. And therefore, beta blockers are in the ESH guidelines first line, while they're a little bit downgraded, particularly in the American guidelines. That's a difference. The good news is that there's a consensus about the target, the optimal target now. Optimal is, we call it a corridor, is below systolic 130 and diastolic below 80. So between, Professor Sturgeon mentioned 125 something. Either office or home to 125, around 125. So there's a consensus, essentially same. Despite the differences in, definition of hypertension, etc., the target in patients with hypertension are basically very, very similar across all guidelines, the European guidelines and the American guidelines. So I think that's an important take-home message. In terms of how to treat, the leitmotif or the key feature now is which we should change, and that's a major issue how to implement this, is that the standard is to start with a dual single pill combination therapy in most patients. So to start with monotherapy should be the exception, not the other way around. So to start with the dual therapy single pill combination in most patients, and there's a consensus in all guidelines. This is the new concept, which is very important. And there's a summary slide for the European guidelines, and the same applies to the American guidelines, basically to start, as I mentioned, with a dual therapy in all guidelines. There's a subtle difference between the ESH and the ESC guidelines in terms of when you start with a dual therapy, usually it's a low dose, a half dose combination therapy, whether to move immediately to a triple therapy, which is recommended by the ESC, so from dual therapy to triple therapy, or whether if you have low dose dual therapy, you might increase the dose first. So there's a subtle difference, and we can argue. I think both ways are reasonable to increase the dose or to move to a triple therapy. I'm personally in favor to increase the dose in most cases, but that's my personal opinion. The other difference I mentioned already is the consideration of beta blockers. That's the other difference. Otherwise, what else, in the treatment algorithm is mentioned, and what we should do, we discussed this already yesterday. Essentially, which is good news, very, very similar. So no major difference in the treatment algorithm, which is important. There's subtle difference and novelties also in the treatment of resistant hypertension. True resistant hypertension means that we confirm the hypertension resistance in response to triple therapy, including a diuretic, using out-of-office blood pressure measurement, exclusion of secondary hypertension. Of course, we have a diuretic on board in all these patients. What we also stressed in the ESH guidelines, the treatment management depending on kidney function. So if the kidney function is above eGFR 30 milliliter per minute or equal, so CKD3 maximum, we use the standard treatment algorithm, and then we may add spironolactone as a preferred drug, a beta blocker or alpha blocker, or a central acting agent. So there's also consensus in all the guidelines. But we may also use renal denervation, the only interventional treatment for hypertension, in those patients if eGFR is at least 40 milliliter per minute. And this is a class 2 recommendation, so an option for patients. And that is similar across all guidelines. So there's also no difference here. I just show for completeness, this is the treatment algorithms for resistant hypertension American and ESC guidelines. There's basically no major difference. If the patients, these are the patients, they should be also, consulted by a nephrologist, of course, ideally. If the eGFR is below 30, CKD4, advanced kidney, there's a different treatment algorithm. Now we switch in those patients the thiazide-like diuretic to a loop diuretic, and we even may combine the loop diuretic with chlorothalidone based on the CLIC trial that has been published. So doing sequential nephrolone blockade to use 2 diuretics, because in these patients that might contribute to major blood pressure lowering effect. In these patients, the mineralocorticoid receptor antagonists are contraindicated, and renal denervation is also not an option. So the guidance of renal function is very important for the patients with true resistant hypertension. And these advanced kidney patients, of course, have very, very often resistant hypertension. So looking into the future, I don't know. So this is eyeballing what will be the future, but of course you expect some information. So what do we anticipate in the future also for the European guidelines? So I asked our president, Thomas Weber from Austria, what will be the future? What's the situation? So I can tell you that we are now in discussion with the ESC to have joint guidelines again, to avoid the schisma between the 2 guidelines, to join forces again, and we hope that it will be fruitful. Although we have some issues, and the major issues, there are not so many issues in terms of hypertension treatment. The major issue, how the nomenclature of elevated blood pressure and whether patients without hypertension, meaning below 140/90, should be treated with drug therapy quite intensively as they stated in the guidelines. So we have to see, and I think we will learn we have a plan in maybe the next couple of months to go together again and develop future guidelines. Of course, when we look into the context, you mentioned the Margarita? No, what was it? Magarena. Sorry. Oh, that was Freud. That was Sigmund Freud. I shouldn't, yeah. Margarita is something different, yes. I know some people, I didn't, but I know some people last night were drinking this stuff. I didn't. Okay, anyway. So CKM, cardiometabolic or cardiorenal, of course, will be a major issue in the future. You may even put the liver into the context, and I think you acknowledge this. But we should not be confused to put everything together and confuse ourselves to also focus on single aspects. And I think I'm a hypertension guy. We should not forget, and maybe the master plan is helpful to do a proper treatment management of hypertension as well as of the other phenotypes. Of course, we anticipate definitely in the next couple of days, weeks, that we will have new drugs approved by the FDA first, and then maybe globally and also in Europe. And of course, the aldosterone synthase inhibitors are very, very promising drugs. First indication will be difficult to control or resistant hypertension. But we will also have new options with established drugs. And I think for management, it's very important to manage hypertension with a single pill. We discussed yesterday, taking the drug in the morning or the evening or whatever, but once per day, a single drug with dual therapy, triple therapy, to have the option to adjust the doses, or even in the future, by Xavier, a new compound, I can mention this, a new tablet that has 4, including a beta blocker, a beta-1 selective beta blocker. So that will be also a tool available to us in the future for hypertension management, for substitution therapy, or for therapy of resistant hypertension. That brings me to the end, and again showing the data. I think that the discussion about elevated blood pressure to treat patients with a blood pressure of 130, 80, etc., should not, withhold the management, the proper evidence management of those patients. There are so many with hypertension. and control the blood pressure below 140 or 190. And we know that the major benefit is even if we lower the blood pressure below systolic below 130, which is a challenge. And I think we should work together, and I'm excited and very happy to see how active the Greta group is in this regard. So we will further discuss this issue also in Danz. Maybe some of you have the possibility to come to the ESH meeting in Danz. I would like to thank you very much for listening to me and for inviting me again. Thank you.
Thank you very much, Professor Kreutz. ¿Tendremos tiempo para alguna pregunta o no? Well, can you take a question from the audience? ¿Alguna pregunta para el profesor Kreutz o comentario? No questions. Everything was so clear that there is no questions, my friend. Thank you very much for your participation.